Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of larynx into clear, high-yielding, exam-focused concepts. So let's get started. So the larynx in Greek, it means the windpipe. Laryngeus means the windpipe. Okay, so it is the upper expanded part of the lower respiratory tract. So this larynx is mainly for respiration as well as for phonation. The other functions of it also helps in deglutition and also it protects. Now, this larynx is situated in the midline of the upper part of the neck, okay, above the trachea and in front of the laryngopharynx. So, if you see, it extends from the root of the tongue, okay, so from the root of tongue, it extends up to the trachea. So, when we see, so this part will be the larynx. So this larynx, it lies in front of the third, fourth, fifth and sixth cervical vertebrae. So it will be in relation to this 4 cervical vertebrae. In children and in females, it will be slightly higher a level. So when we see the measurements of the larynx in males, it is, so if we see the vertical into transverse into anterior-posterior diameter, when they see in males, it is about 44 millimeters into 43 millimeters into 36 millimeters. Whereas in females, it is about vertically, it measures about 36 millimeters into 41 millimeters into 26 millimeters. So till puberty, the larynx of both male and females is almost same. But at puberty, what happens in males is the larynx grows more rapidly and becomes larger than the female larynx. So when we see the skeleton, okay, so the skeleton framework of the larynx will consist of cartilages. So there are cartilages, then there are membranes, okay, fibrous membranes, then there is ligaments, okay, and muscles are also present, okay. So the skeleton of the larynx includes the cartilages, the fibrous membranes, then the muscles as well as the ligaments. So we will study briefly about the important aspects of all these structures. So when we come to the cartilages of the larynx, okay, so the larynx has got 9 cartilages. There are 9 cartilages which we see in the larynx, of which 9 total, 3 are unpaired and 3 are paired. So you have to know which are the paired and which are the unpaired, because that is one of the common MCQ which is asked. So when we look at the unpaired cartilages, okay, so here if we see, we have the epiglottis, then we have the thyroid cartilage, and we have the cricoid cartilage. So these 3 cartilages, they are unpaired, okay, they are single. Whereas the paired cartilages, when we see, we have the arytenoid, okay, here we have the arytenoid, then we have the corniculate and the cuneiform. Okay, so these are the paired cartilages which are in pairs. The arytenoid, on the top of that there will be the cuneiform and the corniculate. Corniculate and the cuneiform above the arytenoid. So we have 3 paired and 3 unpaired cartilages. So here usually when we talk about the principal cartilages of the larynx, we talk about the cricoid, thyroid and the two arytenoid cartilages. So here we have to understand that the thyroid, so out of these cartilages, okay, in the nature, the thyroid and the cricoid cartilage, okay, so the thyroid, the cricoid and the basal part of arytenoid. Okay, so arytenoid, so these are composed of all hyaline cartilage. Okay, so these are made up of hyaline cartilage. So these ossify only after 25 years of age and can be seen on the radiograph also. So when we take a radiograph of the neck region, we will be able to see these cartilages. Okay, so they ossify after 25 years of age. Okay, they ossify. Whereas the other cartilages, okay, the other cartilages, that is the epiglottis. So we have the epiglottis here. The epiglottis, the corniculate, and here we have the cuneiform and the corniculate. These three, they are as well as the apical part of this arytenoid, okay, apical portion of arytenoid. They are all made up of elastic cartilage. Okay, so basically we will see two types according to their composition. So hyaline cartilage and elastic cartilage. So hyaline are thyroid, cricoid and the basal part of arytenoid. Whereas the epiglottis, the corniculate and the cuneiform, they are elastic along with the apical portion of arytenoid. So that is about the cartilages. Then coming to the joints of the larynx. So here we see a 𝗕𝗵𝗂𝗏𝗏𝗏. So here we can see this is the 𝗕𝗵𝗂𝗏𝗏𝗏 joint. Then cricoarytenoid. Okay, so here this is the cricoarytenoid. And here we see the arytenocorniculate. So these are the three joints of the larynx. So this cricothyroid joint is basically plain synovial type of joint. It is a plain synovial joint. So this basically helps in there are very slight movements in regards to the joints of the larynx. So slight rotatory and gliding movement happens here. Then there is this cricoarytenoid. This is also a plain type of joint. So this is also plain type of synovial joint, and that also helps in rotatory and gliding movements. Then this joint, it is a very small joint. It doesn't have its plain synovial joint too, which doesn't have any functional significance. Okay, no functional. The arytenocorniculate doesn't have any such functional significance. So these are the three joints which you should know in regards to larynx. Then we come to the ligaments. Okay, the ligaments and the membranes. So when we talk about the ligaments and the membranes, here we have what we call it as the extrinsic membranes and the intrinsic membranes. Okay, extrinsic membranes on the outside and intrinsic membrane towards the inside, as the name says. So we will see which are the extrinsic membranes. Okay, so extrinsic membranes, they lie outside the inner tube of the laryngeal cavity. So we have here, if you see from, this is the hyoid bone here. So this is the hyoid bone. So this will be from the thyroid cartilage to hyoid bone. This is the thyroid, thyrohyoid, thyrohyoid membrane, and from the cricoid to the first ring of the trachea, here we have the cricotracheal ligament. So here if we see, the thyrohyoid membrane will be extending from the upper border of this thyroid cartilage up to the upper border of the hyoid bone. So between the posterior aspect here, hyoid and the membrane, there will be a bursa, okay, subhyoid, which we call it as the subhyoid bursa. So the median, okay, so here if we see the median and the lateral part, okay, so lateral parts, the thyrohyoid membrane will be thickened, okay. It gets thickened to form the median. It forms the median and lateral, okay, and lateral thyrohyoid ligaments. So, the median and the lateral part of this thyrohyoid membrane will be thickened, and we call it as the median and lateral thyrohyoid ligaments respectively. Now, along this lateral thyrohyoid, okay, thyrohyoid ligaments, there will be a small elastic nodule which is present in this area. So, that elastic nodule, we call it as the, okay, so why we call elastic? Because it has elastic cartilage. It's basically made up of elastic cartilage, that nodule. So, that nodule, we call it as the cartilago-trytca. Okay, 𝗙𝗪𝗚𝗓. So, that is nothing but a nodule which is made up of elastic cartilage on the thyrohyoid membrane. Right, then we have the cricotracheal ligament, I said. Then from the thyroid, okay, so posteriorly we'll see from the thyroid to the epiglottis, we also see the 𝗘𝗵𝘃 membrane. Okay, 𝗘𝗵𝘃 membrane. So this is 𝗘𝗵𝘃 membrane. Then from the hyoid to the epiglottis, we will see the 𝗖𝗵𝘆. Okay, 𝗖𝗵𝘆. And from the cricoid to the thyroid, we will also see cricothyroid. So these are all the extrinsic membranes. Okay, so from below upwards as we go, to remember it easily, we have the cricotracheal, cricothyroid, thyrohyoid, membrane and ligament, then 𝗘𝗵𝘃 and 𝗖𝗵𝘆. Okay, and this is what I told you is the 𝗘𝗪𝗚𝗡𝗡𝗅. Okay, so that is a elastic cartilage nodule which we see on the thyrohyoid ligament. So these are all the extrinsic membranes and ligaments. Coming to the intrinsic, okay, so the intrinsic ligaments are which we see within the interior. So these are all parts of the broad sheet of fibroelastic tissue. Okay, so they are made up of fibroelastic tissue. So now here we see a sinus. Okay, so this is the sinus of the larynx. So this is the sinus of the larynx. So this part above this sinus, we call it as the quadrate. Okay, so this part we will be calling it as quadrate, or also called as the quadrangular ligament. Quadrangular, since it is spread, we call it as quadrangular membrane. Okay, so this portion above the sinus, we call it as the quadrate or quadrangular membrane. And the part below, okay, so this part we are going to call it as the cricovocal membrane. Cricovocal vocal membrane or conus elasticus. Okay, so that is below the sinus. So here the cricoid membrane, if you see the upper margin, okay, so this upper margin here it forms a fold, okay, it is slightly thickened there, it forms a fold which is thickened, which we call it as the vocal ligament. Okay, this is vocal ligament. And when this vocal ligament is covered by the mucous membrane which is present in that region, we call it as the vocal fold. So, vocal ligament with the mucous membrane, we call it as the vocal fold. Okay, together we call it as the vocal fold. So, that is here. And if we see the quadrangular membrane, okay, it will be extending from the sides of the epiglottis up to the arytenoids here. So, here the lower end is free, okay, lower end is free and it forms a fold, okay, it forms a fold, and that fold we call it as the vestibular ligament. Vestibular ligament. So, that is about the intrinsic membranes and the ligaments, okay, so which we see in the interior of the larynx. So next we move on to the muscles, okay, so the muscles of the larynx. So when we look at the muscles of the larynx, we divide them into two groups, the extrinsic muscles and the intrinsic muscles, and as the name says, extrinsic, they have the origin elsewhere, but they are getting inserted around the cartilages of the larynx. And when we say intrinsic, they have the origin and insertion within the larynx itself. So, the extrinsic muscles here include the palatopharyngeus, salpingopharyngeus, stylopharincus, thyroid and sternothyroid muscle. Okay, so they are the muscles which are extrinsic. So, coming to the intrinsic, to remember it easily, okay, and based on their action, we divide it into three groups. So, the first group is one which opens or closes the laryngeal inlet, okay, which opens or closes. The second group is one which adducts and or abducts the vocal cords. And the third group is which increases or decreases the tension of vocal cords. So, here the one which opens the inlet, okay, so there is only one muscle which opens the inlet. So, here to remember these open or close, okay, you can remember oat, okay, oats, no, so we have oat. So, of this, the oblique arytenoids and the array epiglottis, okay, oblique arytenoids and the array epiglottis. So, these muscles, they will close when they contract. Whereas the 𝗘𝗅𝗵𝗃𝗧, that is from the thyroid to the epiglottis, so when it contracts, it will open the inlet. Okay, so 𝗘𝗅𝗵𝗃𝗧 is the one which will open. So, this is about the muscles which open or close. Then we have the adductors and abductors of the vocal cord. So, here, okay, you can remember as LTP. So, the adductors, only two adductors are there. So, that is the lateral cricoarytenoids and transverse arytenoids. Okay, they have to bring closer. So, transverse will be transverse. So, when it contracts, it brings it closer. So, transverse arytenoid and lateral cricoarytenoids. So, when they adduct, they bring about the adduction. Abductor is only one, the posterior cricoarytenoids. It is known as the safety muscle. Okay, so safety muscle of the larynx, posterior cricoarytenoids, because it will abduct so that the laryngeal inlet doesn't close. Okay, so there is no obstruction to the airway. So that is brought about by this abductor. So posterior cricoarytenoid. Then among the increase or decreases the tension of the vocal cords, we have three muscles, CVT. Okay, So the cricothyroid and 𝗘𝗘𝗧, they are the tensors, whereas the thyroarytenoid is the relaxer. Okay, it relaxes the vocalis or the vocal cords basically, and the cricothyroid and vocalis muscle, they bring about they tense the vocal cords. So this is broad classification of the muscles of the larynx, the intrinsic muscles basically of the larynx. Here also posterior cricoarytenoids, I told you it is the safety muscle. Similarly, we have one more muscle which we call it as the tuning fork of larynx, and that is the cricothyroid. Okay, so the cricothyroid is called the tuning fork of larynx. Okay. So this muscle, why it is called so is because see, it is bringing about the tension of the vocal folds, right? So this muscle is responsible for the tone and pitch of the voice. Okay, so this is responsible for the tone as well as pitch of the voice. So when the sound is about to be produced, it tenses. It is a tensor of the vocal cords. So it tenses the vocal cords and makes it ready to vibrate to produce that sound. Okay, so that is why it is called as the tuning fork. Like a tuning fork, it vibrates. So usually if there is paralysis of the cricothyroid, okay, because of injury to the external laryngeal nerve, it can result in alteration of the voice. So this is basically it is of most significant in case of singers where the voice is very important, right? So that is about the muscles and the important. So you should remember the only muscle which opens the inlet is the 𝗘𝗵𝗵𝗂𝗏. The only abductor is the posterior cricoarytenoid. Okay, cricoarytenoid, and cricothyroid is known as the tuning fork of the larynx. So this is just to know the position of muscles. So here you can see from the arytenoid to the epiglottis, we have the 𝗤𝗵𝗵𝗃 muscle. So what was 𝗤𝗵𝗵𝗃 doing? Epiglotticus muscle. So 𝗤𝗵𝗵𝗃 brings about the closing. So when it contracts, it closes. Then we have the 𝗘𝗅𝗵𝗵𝗃 here. So this is 𝗘𝗅𝗵𝗵𝗃. 𝗘𝗅𝗵𝗵𝗃 opens the larynx. Okay, it's the opener. And then we have so from the thyroid cartilage to the arytenoid, this is the thyroarytenoid muscle. So thyroarytenoid muscle, and thyroarytenoid, what was it doing? Thyroarytenoid was the relaxer of the vocal. So when this contracts in the upper part, the lower part will relax, right? So it is basically relaxing the vocal cords. Then we have the lateral. So here we can also see from the lateral side of the cricoid cartilage to the arytenoid. So lateral cricoarytenoid, and lateral cricoarytenoid was adducting. Okay, so this adducts the larynx. Okay, so adducts the vocal cords, basically adducts the vocal cords. So these are the muscles which we see here, and here also we see some more muscles. So this is again 𝗤𝗵𝗵𝗃. So 𝗤𝗵𝗵𝗃 will bring about closing of the larynx, inlet of the larynx. This is transverse. Okay, transverse arytenoid. Transverse arytenoid. So transverse arytenoid, it will again adduct the vocal cords, adducts the vocal cords. Then here this muscle which is going obliquely here, we have the oblique arytenoids. And the oblique arytenoids closes the laryngeal inlet. Then we have the posterior arytenoid. So this is the posterior cricoid. So it is the safety muscle. Okay, so what does it do? It brings about the abduction. So of the vocal cord. So this is about the muscles and the actions. So next we move on to the cavity of the larynx. Okay, so the cavity of the larynx, when we see, what are the features we see inside the cavity of the larynx? So the cavity of the larynx here, if you see, it extends. So this is the inlet here. Okay, from the inlet up to its lower border. This is here we have so this will be the cricoid cartilage here, the anterior part. So this is anterior here and this is the posterior. Posterior lamina of the cricoid cartilage is more broader compared to the anterior here. So this is the lower border of the cricoid. So this will be up to the lower border of cricoid. So it will extend up to there. Okay, so below it will continue as the trachea. So now here we will see, okay, so anteriorly we have this epiglottis here, and then posteriorly here we have the interarytenoid fold, okay, and laterally on each side this fold here, what we see now here, we are seeing a section, so we are not able to see the posterior boundary, but we can see laterally on each side, this is the epiglottic fold. Okay, so this is the 𝗤𝗵𝗃𝗀 fold we are able to see. So now here, okay, within this laryngeal cavity now, here we will see two folds. So the upper fold and the lower fold. So when we studied about the membranes, right? So there I told you we have the vestibular ligament here. So this vestibular ligament covered by the mucous membrane becomes the vestibular fold. Now this vestibular fold, we call it as the false vocal cords. And down here we had the vocal ligament covered by the vocal fold, basically covered by the mucous membrane, which we call it as the true vocal cords. Okay. So the lower fold formed by the vocal ligament and the vocalis muscle covered by the mucous membrane, we call it as the vocal folds, otherwise the true vocal cords. So between the two, okay, so between now we have to imagine, now we are seeing of one side the vestibular fold and the vocal fold. So between the two vocal folds, the right and the left vocal folds, the space between that, we call it as the rima vestibuli. Okay, and between the two vocal folds, the space we call it as the rima glottidis. So these two terms you have to understand. Now the subdivisions coming to the, so here you can see, okay, so these are the true vocal cords which we are seeing here. Okay, so this will be the 𝗤𝗵𝗃𝗀. Now this is the epiglottis. Okay, so this is the 𝗤𝗵𝗃𝗀 fold. So in the laryngoscope, when we see, we will see like this. Okay, so here we are seeing the vocal cords, the right and left. So the space between the two vocal cords. So here this fold is the vestibular fold. And this fold here is the vocal fold. So the space between these two vestibular folds, we call it as the rima vestibuli, and the space between the two vocal folds, we call it as the, so this space is known as the rima vestibuli. And this space here between the two vocal folds, we call it as the rima glottidis. Now let's see the subdivisions of the laryngeal cavity. So the laryngeal cavity now, it is subdivided into 3 parts by the 2 ocal folds and the 2 ocal vestibular folds. Okay, by the pair of these vestibular folds and by a pair of these ocal folds, the laryngeal cavity is divided into 3 parts. So first part here, we call it as the vestibule. Okay, so that otherwise also called as the supraglottic compartment. Okay, it is called as the supraglottic compartment. So it is basically a supraglottic compartment extends from the laryngeal inlet up to the vestibular fold. So this portion is the vestibule. Then we have the ventricle. Okay, so this small space here, right? So this is, we call this elliptical space here, we call it as the ventricle. And then the lower part, okay, this is the infraglottic compartment, that is from the ocal folds up to the lower border of the cricoid cartilage. So up to there we have what we call it as the infraglottic compartment. So here in the ventricle we will see one feature. Okay, so this is like we saw the section. So when we take a coronal section, we will see something like this. So here we have, this is the epiglottic fold here. Okay, so this is the epiglottic fold. And here we see this is the pyriform fossa, where the foreign bodies are usually lodged. Okay, so usually the fish bone gets stuck here. Okay, so in this part, that is the pyriform fossa. It's a common site for foreign body. And then we have, this is the inlet here. So this portion is the inlet of the larynx. So this becomes the vestibule. So this is the ventricle, otherwise also called as the sinus. So here if you see on each side, okay, the narrow blind diverticulum is formed here. Okay, this one. So this diverticulum is a diverticulum of the mucous membrane. So it will extend posteriorly and superiorly between the vestibular fold and the lamina of the thyroid cartilage. So this fold. So this we call it as the saccule. The saccule is provided with a very rich supply of this mucous glands. Okay, so there are a lot of mucous glands there, and that secretions, okay, so these mucous glands produce the secretions which will lubricate the vocal cords. So that is why it is known as the oil can of larynx. This saccule is known as the oil can of larynx. These mucous glands present in the saccule. Okay, so that is in the ventricle. Then we see the this is the infraglottic part. Okay, so here now even we see, so vestibule separated by these are the vestibular folds which we see here, and this is the false vocal cords, this is the true vocal cords, which are nothing but the vocal folds. And this is the, below that we have the infraglottic compartment. Okay, so this space what is between the two vocal cords, we call it as the rima glottidis, and this space we call it as the rima vestibuli. So that is about the interior of the larynx. So here we studied about the ventricle, and in the ventricle about the saccule, right? So sometimes what happens, if the pressure, okay, if the air pressure within the laryngeal sinus is raised, okay, it's increased very much. Especially this happens in case of trumpet players, okay, trumpet players, glass blowers is those who are in the glass manufacturing industry, right? So when they blow the glass, Okay, or also in case of weightlifters, heavy weightlifters. Okay, in those people, what happens? The air pressure within the larynx is increased. So because of which what happens is the saccule, if you see here, gets dilated. Okay, and this dilatation, basically it is an air-filled dilatation. We call it as the laryngocele. Okay, so this one is known as the laryngocele. So this laryngocele can be internal when it is inside, located within the larynx, or it can be external. So if it is here, it is internal within the larynx, or this can be external when it herniates. Okay, when it herniates through the thyroid membrane, we call it as the external laryngocele. So this is a clinical condition associated with the saccule. So we can see it here. This is a kind of internal laryngocele. And here we see the external. Okay, this is the external when it herniates through the thyroid membrane. Okay, comes outside. So this is a common clinical condition we see. So sometimes the mucous membrane, okay, so the mucous membrane of the superior part of the larynx, okay, so that is the upper part, right, the supraglottic part there is very sensitive. So what happens is whenever a foreign body enters, okay, when the foreign bodies enters into the laryngeal inlet, it will immediately, as a reflex action, it produces explosive coughing and the foreign body is expelled. So that is the normal response. But if that reflex is slowed, okay, that coughing reflex is slowed or absent. So usually in cases of maybe some neurological disorders or in cases of like alcohol, consuming alcohol, right? So it may be slowed. So in those cases, the foreign body can enter, okay, the laryngeal cavity and it can cause choking or laryngeal obstruction. So in those cases, what happens? It may lead to asphyxia, obstruction leading to choking and asphyxia. So immediately the foreign body has to be dislodged. Okay, otherwise, since the airway is obstructed, the patient can die. So usually to relieve of the obstruction, we perform a maneuver, and that maneuver we call it as the 𝗕𝗵𝗔𝗟 maneuver. Okay, so this is what we do, 𝗕𝗵𝗔𝗟 maneuver. So in 𝗕𝗵𝗔𝗟 maneuver, we stand behind the victim, pass our arms around, okay, under his arms and place the hands in front of the victim like this. Place the hands in front of the victim and we thrust the pressure, okay, in front of the victim's epigastric region with one hand forming a fist. So you can see one hand is forming the fist and the other hand lying over it. Then we give the abdominal upwards, okay, about 3 to 4 abdominal thrusts are directed upwards and backwards. So what happens here? So what is the anatomy or the action behind that? So here the residual air, so when we do like that, the residual air, okay, in the lungs is squeezed up in the trachea. With that pressure is increased, and because of that it can force the dislodgement of the foreign body, right? So thus the laryngeal obstruction can be relieved. So sometimes usually in children and all, we can see that foreign body and then it can be manually removed, okay, otherwise it itself gets expelled out with force. So usually we do, this is the commonest we do, but in children this is how we do. Okay, so we make the hold the baby in one hand, okay, with our and lying across, the chest will be over the thigh region, and then we on the back we put the upward and downward and upward thrust like this. Okay, so in that case what happens is with the heel of the hand we give the thumbs. Okay, so with that the foreign body will be expelled. So we will keep the mouth open so that if it comes, it can be expelled. And in case nobody is there to do the 𝗕𝗵𝗔𝗟 maneuver, in those cases, and if you are choking, what you should do? You should press your abdomen, epigastric region, against the any hard surface, okay, against the table or the chair, and when we lean upon there, okay, so the counter pressure will be developed and the foreign body can be expelled. So that is about Heimlich maneuver. Next, coming to the blood supply. So the blood supply, nerve supply, the venous drainage, okay, of the larynx is different above and below the vocal cords. So vocal cords, we take it as the landmark there, and above and below it changes, okay. So when we talk about the blood supply, so the blood supply differs above the vocal cords and below the vocal cords. So above the vocal cords, it is by the superior laryngeal artery, which is a branch of superior thyroid artery, and superior thyroid artery comes from the external carotid. Then below the vocal cords, okay, below the vocal cords, it is by the inferior laryngeal artery. It is a branch of inferior thyroid artery. So this is the blood supply, whereas the rima glottidis, that portion has dual blood supply from both the arteries. Then coming to the venous drainage, okay. So venous drainage superiorly, okay, when we see in the superior part, it drains into the superior laryngeal vein, it drains into the superior thyroid, okay, superior laryngeal vein. So above vocal cords, it is superior laryngeal vein draining into superior thyroid vein. Whereas below vocal cords, okay, so here you can see this is the superior laryngeal vein draining into the superior thyroid. So below vocal cords, it is again inferior thyroid vein. So finally it goes to subclavian, inferior thyroid vein, okay, inferior laryngeal vein basically going into, so that will drain, inferior laryngeal vein will drain into inferior thyroid vein. That is the thing. So superior laryngeal vein drains into superior thyroid, and superior thyroid will go to finally drain into internal jugular. And in the below the vocal cords, inferior laryngeal vein goes to inferior thyroid, and from here to the subclavian. That is about the venous drainage. Then coming to the nerve supply. Okay, so nerve supply here, the motor supply. Okay, the motor supply is provided by the internal is both by the internal and external laryngeal nerve. Okay, whereas the sensory supply again differs. Sensory supply above vocal cords, it is by the internal laryngeal nerve, and below vocal cords, recurrent laryngeal nerve. Below the vocal cords is by recurrent laryngeal nerve. So here what we have to remember is, in the motor supply, all the intrinsic muscles are supplied by the recurrent laryngeal nerve, like except the cricothyroid, okay, except the cricothyroid, which is supplied by the external laryngeal nerve. Okay, so that is an important fact which you have to know about the nerve supply. So here you can see the supply by the external laryngeal and the recurrent laryngeal. Here we have, as well as we have the recurrent laryngeal nerve supplying the muscles. Right. So next we move on to the lymphatic drainage. So lymphatic drainage, again above the vocal cords, they pierce the thyroid membrane, run along the superior thyroid vessels and drains into, so above vocal cords, it drains into the upper deep cervical lymph nodes, okay, into the anterosuperior group of upper deep cervical lymph nodes here. Whereas in the lower part, below the vocal cords, so below vocal cords, it will drain, okay, it pierces the cricothyroid membrane there and it will go to the pre-laryngeal and pretracheal. Okay, pre-laryngeal lymph nodes and pretracheal group of lymph nodes. And from there, it will drain into the lower deep cervical, that is the posterior-inferior group, lower deep cervical lymph nodes. So that is the lymphatic drainage. So rima glottis. What is rima glottis now? Rima glottis was the space between the two vocal cords, isn't it? The two vocal folds basically. So it is the narrowest, okay, you should know that it is the narrowest antero-posterior cleft of the laryngeal cavity. So it is the narrowest cleft there. And it is about 24 millimeters, okay, 24 millimeters in adult males and about 16 millimeters in females. So this rima glottis, okay, so that is this portion here, this narrowed portion here between the two vocal folds or the two vocal cords. So here it has two parts, okay, so this one will be having, so here you can see this is the rima glottis here. Now this will be having two parts. One we call it as the intermembranous part. Okay, so this will be in the anterior 3/5. Okay, in the anterior 3/5 between the two vocal cords, we will see the intermembranous part, and there is the okay, so here you have to remember it's just a space. So between the two membranes, it is the intermembranous part, okay, and that is in the anterior. And posterior, we will have the intercartilaginous part. So this will be in the posterior 2/5, okay. Posterior 1/5 to 2/5. We will have the intercartilaginous part. So the intermembranous part is between the two vocal folds, whereas the intercartilaginous part is between the two arytenoid cartilages, okay, between the arytenoid cartilage. Now the shape of the rima, we have to remember, it varies with the movements of the vocal cords. So how the vocal cords move, along with that the rima glottis shape also changes. Now if we see during quiet respiration, this is the shape which we see during quiet respiration. So during quiet respiration, okay, this is when we are always breathing. So this will be pentagonal in shape. During quiet respiration, it is pentagonal. So if you see the intermembranous part, it is triangular, and the intercartilaginous part will be rectangular. Okay, so intermembranous, triangular, and intercartilaginous, rectangular. So that this is during the quiet respiration. Then during inspiration, okay, in full inspiration, it is more of diamond shape. So when it is diamond shape, okay, so here what happens? The glottis become very widened. Okay, the glottis widens and becomes diamond shape because of the abduction of the vocal cords. Then we have during high pitched, okay, so when the pitch is very high. During high pitched voice. So during high pitch, it becomes a very linear chink. Okay, so here it will very linear chink because both the intermembranous as well as the intercartilaginous part both are adducted. Okay, so because of that we see it as a linear chink. Then during whispering, so during whispering, what happens? It becomes funnel shape. So funnel shape. So intramembranous will be adducted, whereas the intercartilaginous part will be separated like a triangle. So this will be like a inverted funnel shape. So that is the different shape of the rima glottis which we see during the movements of the vocal cord in different phases of respiration as well as during the phonation. Next is laryngoscope. So laryngoscope is basically the interior, okay, the interior of the larynx can be studied, okay, can be inspected using a laryngoscope. So when it can be a direct or an indirect, okay, so when we use the laryngoscope, that is the direct one. When we use a mirror and see, that is indirect laryngoscope. Okay, laryngeal mirror we use and that is indirect laryngoscope. So what are the structures which we see? So here if we see, okay, so in the laryngoscope we will see the base of the tongue, then we see the vallecula. This is the median fold and here the space what we are seeing, this is the vallecula. Then we see the epiglottis. This is very important when you are trying to insert a tube, ET tube, okay, endotracheal tube. You have to know what structures, when you use a laryngoscope and try to insert, you have to know what structures you are going to see. Then we have the epiglottic fold. Then we have the piriform fossa. Okay, so here we see the piriform fossa here. Then this is the false vocal cords. Okay, they will be reddish, like because of the mucous membrane there, they'll be more reddish. Whereas this one true will be pearly white, glistening. This is the true vocal cords. Which will be just medial to the false vocal cords. Okay, you will see. And the sinus, between these two, the space will be the sinus. Okay, so these are the structures which we see in the laryngoscope. Okay, so here you can see this is the laryngoscopic view of the laryngeal cavity during moderate respiration, and you can see that the rima, this is the rima which is opening. Okay, so here we can also notice that this portion, the laryngopharynx, will remain closed. Then there is a condition which we call it as the ocal nodules, or it is also called as Singer's nodules or Screamer's nodules. Okay, Singer's nodules. It also has different names, Singer's nodules, or also called as Screamer's screamer. Okay, this is Screamer's nodules. So during vibration, during vibration, the area of maximum contact between the two vocal cords is at the junction. So when there is vibration, right? So the maximum area of contact will be at the anterior junction of anterior 1/3. It will be at the junction of anterior 1/3 and posterior 2/3. So this is the area of maximum contact. Okay, so that is during the vibration. So in individuals who overuse their voice, so what happens? There is friction between these two areas on either side at this junction, and because of which the inflammatory nodules, these are all inflammatory nodules developed there. Inflammatory nodules develop at the site, which we call them as the vocal nodules. So usually they are bilateral. They are present on both the sides. Bilateral. They are symmetrical and vary in size. So it can be as a size of pinhead as up to a pea size also. So in the early stages, what happens? They are soft, they are soft, reddish and edematous, this swelling there. But later they become greyish white. You can see here, it becomes greyish white in color. So when it becomes like that, it needs to be removed, surgically removed. But if it is reddish white, in those cases, we can teach them voice modulation, voice rest, all those things, speech therapy, and we can control that condition. So this is how it is seen. At the junction, you can very easily know this is the posterior 2/3 and anterior 1/3 junction. Here we can see the nodules. This is the Singer's nodules. Now let's look at some of the image-based MCQs. So here the sagittal section showing epiglottis folding backwards during swallowing, covering the laryngeal inlet. So which muscle is responsible for pulling the epiglottis downwards? Which are the muscles which close the inlet? We have oblique arytenoid and array epiglottis. So which muscle is given here? It is the array epiglottis muscle. So posterior cricoid is an abductor, 𝗙𝗃𝗏𝗏 is an adductor, and 𝗙𝗃𝗏𝗏 is basically a relaxer, and cricoid is basically a tensor of the vocal cords. So that is how we rule out, and array epiglottic muscle is basically the one which closes the inlet. The posterior view of larynx showing a pair of muscles attached to the cricoid lamina and arytenoid. So from the cricoid lamina to the arytenoid cartilage, what is the action of this muscle? So from the so this is the posterior aspect of the cricoid cartilage. So from here to the arytenoid, so it will be posterior cricoarytenoid. So posterior cricoarytenoid brings about abduction of the vocal cords. So the muscle is basically the posterior cricoarytenoid. Laryngoscopy showing one vocal cord fixed here, we can see in the paramedian position while the other moves normally. Which nerve is most likely to be injured? Here we have the recurrent laryngeal nerve which is likely to be injured. Coronal section showing a space between false and true vocal cords. Identify the structure. Between the false and true, we have the ventricle here. Right, ventricle or otherwise called as the sinus. So, laryngeal ventricle is the right answer. So, that's a wrap on today's session of anatomy of larynx. So, stay consistent, stay focused. This series bring you one step closer to your NEET PG dreams. So, trust in your preparation. That's all for today and I'll see you in the next session.